So I'm going to talk about the really important topic of weight gain in women with HIV. But before I start, I'm going to think about the global context of weight in the world. Since 1975, there has been a tripling of people defined as obese worldwide. So that is adults living with a BMI greater than 30 kilograms per meter squared. And of those living with both obesity and being overweight, the majority are women. And the clinical implications of being obese are major. There's an increased risk of poor pregnancy and birth outcomes for both mother and child, an increased risk of Alzheimer's disease, type 2 diabetes, cardiovascular disease, but also musculoskeletal disease resulting in poor mobility and ability to work. In addition, for women, there's an increased risk of cancers such as breast, ovarian and uterine cancer, as well as GI cancers. All of these result in a 4-year reduction in life expectancy. And putting this in a context of people living with HIV with a normal life expectancy when on effective therapy, this is significant. So what are the factors associated with weight gain and raised BMI in those people living with HIV? I'm going to talk about baseline demographics, HIV and antiretroviral therapy, comorbidities and life events, and lifestyle, all in relation to women. If we think about baseline demographics, 52% of the world's population living with HIV are women. So that is 19.1 million girls and women are living with HIV globally. And the age distribution of women living with HIV has changed over the years. This, for example, is data from Europe, which shows that as we have less women being diagnosed with HIV and more people being treated and surviving with HIV, the age of women living with HIV has increased significantly over time. Despite this, we do not know enough about women's response to antiretroviral therapy in clinical trials. There are significant biological and hormonal gender differences for women. There are different pharmacokinetics for women and side effect profiles. But historically, we have under-recruited women to trials, and despite talking about this at quite length, we have not increased the number of women being recruited to trials, with an average 23% of those participants in 544 studies in the systematic review only being women. So what about HIV and antiretroviral therapy's effect on BMI? I'm going to talk about timing of diagnosis, CD4 count and viral load, and briefly pharmacogenomics. Women being diagnosed with HIV, the numbers are decreasing worldwide. However, in data coming from ESCADE from Europe, what unfortunately we still see that nearly 50% of women being diagnosed are still being diagnosed late, with an average of 3 years from infection to diagnosis. Why is this important? It's important because a systematic review of weight gain in those on antiretroviral therapy showed very significantly that a lower CD4 count, less than 200 cells per millimeter cubed, has a 4 times likely risk of weight gain in antiretroviral therapy. And those with an HIV viral load greater than 100,000 copies per mil have a 2 times increased risk of having weight gain during antiretroviral therapy. So late diagnosis has a higher risk of weight gain when on treatment, and women are more adversely affected. What about pharmacogenomics? There's not a lot of data looking at gender differences in this, but this is one study looking at switching from efavirenz to integrase-based antiretroviral therapy and looking at weight gain. And this study has shown is one of many studies to show no consistent gender difference. So that's some good news for women. If we think then about HIV and its antiretroviral therapy in relation to weight gain and raised BMI, well, this is where the real news is. This slide shows data from NA-ACCORD, which is a large cohort study from the United States and Canada. And as we can see, globally, weight has been increasing. Adults starting HIV treatment and weight has also changed over the years. And what we can see is that since 1998, there has been a doubling of adults starting antiretroviral therapy with baseline obesity. When this group looked at which individual risk groups were more particularly affected, they found white women with HIV had a higher BMI after 3 years of antiretroviral therapy compared to age-matched white women in the control group. So the big news really was Advance and NAMSTAL. So Advance looked at 3 different antiretroviral arms, 2 dolutegravir-based, 1 efavirenz-based, and looked at weight gain at week 96. And what we can see very clearly here is that there is a higher weight gain in both dolutegravir arms in both men and women, but it is most significant in women at 96 weeks on the dolutegravir FTC TAF arm, with a mean weight gain of 10 kilograms versus 5 in women versus 5 kilograms in men. Similarly, the NAMSTAL study, which had 2 study arms, dolutegravir versus efavirenz-based arms, looking at HIV treatment in men and women, again showed higher weight gain in the dolutegravir arm in both sexes, but most significantly in the female arm. And is this significant? Is it just a return to normal weight? No, it isn't. What we are seeing is treatment emergent obesity in the NAMSTAL study, 12% in the dolutegravir arm versus 5% in the efavirenz arm. Advance went further to look at risk of cardiovascular disease and diabetes in individuals aged over 30 in their study. And what they found was a significantly increased 10-year risk of cardiovascular disease and diabetes in individuals in the dolutegravir FTC arm of the study. There's no gender difference shown on this study, but the next slide shows the Advance trial and emergent treatment metabolic syndrome, which shows very clearly at 96 weeks in all 3 arms, there was a higher rate of treatment emergent metabolic syndrome in the TAF FTC dolutegravir arm. But when we look at the gender difference in women versus men, we can see that women are clearly more affected than men. And we know metabolic syndrome is a risk for cardiovascular disease and diabetes. What about the weight gain and where it's deposited? Is it muscle? Is it fat? Advance looked using DEXA to assess fat and lean mass gain. And again, they looked at this in men versus women. And what we can see here between weeks 98, there has already been a fat and limb trunk gain signified by the yellow and brown blocks in both men and women, but it is more significant in women and even higher at week 96. So if we then move on to comorbidities and life events in relation to women, I'm mainly going to talk about menopause and pregnancy. In Europe, 51% of cardiovascular deaths are attributable to women, not men. And the risk of cardiovascular disease in postmenopausal women is double that of premenopausal women. Therefore, we must be really good, surely, at assessing cardiovascular risk in women, given that we know this information. We're not. The POPPY study on this slide shows very clearly that when women living with HIV were assessed to see whether or not they met the criteria to be on lipid-lowering drugs, so LLDs, 79% weren't. When we looked at women who should have been on antihypertensive treatment, we found that 56% met the eligibility criteria with high blood pressure, but weren't on treatment. So we are really poor at assessing cardiovascular risk in women. The only comfort that we can draw from this slide that it's slightly better in women living with HIV than those without. What about pregnancy? So Dolphin 2 looked at dolutegravir versus efavirenz-based treatment in pregnancy. And as well as neonatal outcomes, they also looked at postpartum weight gain. And they found a higher postpartum weight gain in women on dolutegravir arm in both countries, in Uganda and South Africa, in which participants lived, but it was more significant in the South African arm, once again bringing up the genetics and pharmacogenomics theory associated with weight gain. We know that dolutegravir has been significantly studied in Botswana, where it has been used in women of childbearing potential, and neonatal outcomes have been studied, but also birth and weight outcome studies have also been studied. So in women receiving dolutegravir versus efavirenz, they have an average baseline weight, which is the same, But the second trimester gestational weight gain is higher in women receiving dolutegravir versus efavirenz. So what is the outcome of this? Well, actually none. There is no substantial impact in that second trimester weight gain. What we do see, however, is that there are problems if there is a very low baseline weight or a very high baseline weight. But actually, dolutegravir and weight gain did not have a significant impact in this study. In the IMPACT 2010 study published in The Lancet earlier this year with regards to neonatal outcomes, they also have studied weight gain in relation to pregnancy outcomes. So this is a study of 3 arms, 2 of which are dolutegravir based, 1 is efavirenz based, given to women after the first trimester, looking at various outcomes. And what they have found is that there is a higher weight gain in the dolutegravir arms in the dark blue and pale blue in the graph on the bottom on the left. And there are changes in weight over the course of pregnancy, which are more significant in the dolutegravir arms. So what does this mean? Well, actually, what they found was that the higher average weekly weight gain had a lower risk of any pregnancy outcome which was adverse. And in fact, a lower weight gain was significantly associated with a higher risk of an adverse pregnancy outcome. And in this study, what they found was the second and third trimester weight gains found in the dolutegravir arm approached those of women without HIV with normal pregnancy weight gain. So this is actually where weight gain can have a positive outcome. So what about lifestyle? Well, we all need to talk to our patients about alcohol, pre-prepared food, which is far more prevalent, low exercise levels, and an obesogenic environment. And we know that we've all been working from home. Well, some of us have been working from home, a lot of us haven't, but our patients and most of the individuals living in the community have actually been working from home, and they've been in lockdown. And we know that there have been higher rates of people using alcohol and takeaway services during this time with lower exercise levels. So our obesogenic environment in which we already live has significantly increased during COVID. We've also had less time where we've actually seen our patients face to face. We've taken their blood pressure, we've weighed them. So all of these are things which we need to really assertively address with our patients during consultations when we next see them, because gaining weight is a real problem and we need to help patients with this. So in summary, multiple factors can increase the risk of weight gain in women versus men living with HIV. We know for women that this risk starts at HIV diagnosis, with a higher proportion of women being diagnosed late than men, and it continues throughout a woman's life, with pregnancy and menopause both potentially affecting weight and cardiovascular risk respectively. Antivirals will have a different effect on women versus men, and lifestyle is something that we have to address with all of our patients. Concerns about weight gain have been demonstrated in NANSAL and advance very clearly with a gender difference and with long-term potential consequences. However, pregnancy weight gains have not been shown to have adverse outcomes, and this is really important to remember when we are seeing women. That not all weight gain may be deleterious, but for weight gain outside that specific circumstance of pregnancy, it's important to deal with this seriously, to counsel a patient about the long-term harm and excess weight gain can cause, because we don't want to reduce the benefit that we have gained from having HIV treatment being effective and having a normal life expectancy, excuse me, for it to be adversely affected by something like weight gain. Thank you very much.